All right, let's dive right into the fourth and final capstone explainer of our cervicogenic dizziness series. We've tackled the neuroanatomy, we've nailed down the diagnostic rule-outs, and we've gone through the treatment protocols. But today is where the rubber really meets the road. We're getting into real-world clinical timelines and objective discharge metrics. If you manage dizziness in your clinic, this is absolutely crucial. This explainer is based on the literature review titled Cervicogenic Dizziness, Diagnosis and Management, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com. So picture this. You've got two patients standing in front of you at the critical 8-week mark. One is doing fantastic, they've beautifully responded to your combined therapy, but the other? The other is still struggling, still feeling unsteady. What exactly separates these two clinical scenarios? Well, it all comes down to a retested baseline, seeing that objective drop in the neck disability index, the improvement in joint position error, and having a clean differential rescreen. That is what makes your decision-making truly objective, not subjective.
To get us to that level of clarity, here is our roadmap for today. First, the outcome tracking protocol. Second, how to handle the dreaded week 6 plateau. Third, mapping out onward referral pathways. And finally, we'll wrap up the series.
Okay, moving right into Section 1, the Outcome Tracking Protocol.
Let's anchor this right to the patient's actual recovery timeline. The good news here is that cervicogenic dizziness generally has a highly favorable prognosis. If you're using a combined manual therapy and vestibular approach, most of your patients are going to respond within an 8 to 12-week window. So practically, that means an initial retest at week 4, your primary objective review at week 8, and by week 12, you're usually looking at expected recovery and discharge.
But to track that timeline properly, you need an assessment battery, basically your clinical outcome scorecard. You've got to retest the patient every 4 to 6 weeks using these exact metrics: the neck disability index, the dizziness VAS, the joint position error measured in degrees, and functional balance assessments like the functional gait assessment and the ABC confidence scale. You document the baseline on day 1 and then log those 4, 8, and 12-week values.
Because here is the undeniable truth. Numbers, not phrases, drive the discharge letter and any onward referrals. Patients with dizziness, they often use these kind of vague phrases. I feel like I'm floating, or swimming, or just off. Relying purely on those subjective descriptions is a massive trap. Objective data just completely strips away that subjectivity, giving us a crystal clear picture of either progress or failure. So what numbers are we actually looking for? Here's your first key clinical threshold. For a response to really be considered meaningful by that 8-week mark, we want to see the neck disability index drop by 5 or more points. That is the proof that your manual therapy is genuinely impacting the cervical dysfunction. Next up, we need to see a drop of 2 or more on the dizziness visual analog scale by week 8. Look, if their symptom intensity isn't dropping by at least 2 points, that sensory mismatch, it's definitely still highly active.
And for our final tracking target, the joint position error, or JPE. Through your proprioceptive retraining drills, that JPE laser pointer test absolutely must drop to under 5 degrees. Consistently hitting under 5 degrees is a huge signal. It tells us the deep cervical muscles have finally recovered their proprioceptive accuracy.
Moving on to Section 2, the week 6 plateau. Because let's be real, practice isn't always perfect.
I want you to ask yourself, what happens if your patient just plateaus? Or what if they only show a partial response by week 6? Their NDI is stuck, their VAS isn't budging. This is a crucial pivot point where your routine tracking has to shift into active clinical rescreening. A plateau at week 6 is an immediate red flag. It's your trigger to start digging for underlying dual pathologies. Remember, true cervicogenic dizziness rarely happens in total isolation. Usually you're dealing with a concussion or a whiplash injury that caused both a cervical strain and a vestibular insult. So if they stall out at week 6, you must rescreen for vestibular hypofunction using VHIT or calorics, and you've got to rescreen for vestibular migraine. These secondary issues are notorious for masking the recovery of the neck. Which leads us straight into Section 3, onward referral pathways. Knowing when to stop and who to call is literally just as important as the therapy itself.
Let's walk through this decision tree. If your week 6 rescreen points to suspected vestibular migraine, your referral pathway is straight to neurology for prophylaxis co-management. What if the patient has persistent whiplash complicated by PTSD? Refer them to clinical psychology for trauma-focused therapy, because honestly, their nervous system just isn't going to settle until that trauma is addressed. Now, if you uncover cervical radiculopathy or progressive neurological signs, that mandates an immediate referral for a spinal surgery opinion. And finally, if they've got persistent dizziness despite your combined manual and vestibular program, send them over to a vestibular physician for a comprehensive diagnostic retest.
I really want to reinforce this clinical pearl right from our source material. The differential diagnosis often shifts at the 6-week review. It makes total sense if you think about it. As your manual therapy clears away those early cervical drivers, the hidden primary pathologies, maybe it's a subtle hypofunction or an emerging migraine pattern, suddenly unmask and become the dominant driver of the patient's unsteadiness. And that brings us right back to the absolute golden rule of this field. The cervicogenic label is correct only when vestibular and central causes are entirely excluded. Listen, if you refer a patient onward and a central cause is found, it doesn't mean your therapy failed, it just means the diagnosis evolved. At the end of the day, a combined therapy approach, co-managing with specialists when you need to, is what ultimately wins for the patient.
All right, Section 4, the series wrap-up.
This concludes our 4-part series on cervicogenic dizziness. Core message: diagnosis is by exclusion plus positive cervical signs, and combined therapy delivers the 8 to 12-week response. The full literature review and cheat sheet are available at AustralianDizzinessClinics.com.
For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series.